Hello, folks. All right, we're going to talk a little bit about simple pharmacology for the EMT, and then a little bit some more about respiratory emergencies. We could cover some of that when we talked about oxygen. And then we'll spend a few minutes talking about allergic reactions. All right, so hopefully you see the right screen. Some general information. Pharmacology is the study of drugs and their effects. There are some simple drugs that, as an EMT, that you will be able to carry and administer. And then there are some drugs that patients have pre-prescribed for them that you'll be able to assist them in taking. First of all, drug names. There are several different names for drugs. There's a generic name. There's very specific names. For example, the chemical name, which nobody uses except chemists, I guess. But the generic name is pretty common. So here's one, it's called propranolol. And it's a beta blocker, which slows the heart and makes the heart pump a little more effectively. A lot of people are on beta blockers. And then there's the brand name that the manufacturer gives it. And in this case, Inderal. So if you have a prescription for this, it might say propranolol as a generic name on the bottle, but a lot of people call it Inderal. So different names for drugs, okay? So what we need to do, first of all, we need to know the indications for a drug. And indication is the reason why we give somebody a drug. Then we also need to know the contraindications. And contraindications are the reasons not to give a drug because there's something else going on. We need to know the form of the drug that we're giving. Several drugs come in different forms. We need to know the dosage. So we're giving the right amount of that drug. We need to know what we expect to have happen with our patient once they've been given that drug. And we also need to know what possible side effects there are, okay? And then unfortunately, there may also be some untoward effects. Some people may have a reaction to something or have an adverse effect to a drug. For example, Benadryl. It's an antihistamine, usually makes people sleepy. With some people, it makes it so they can't sleep. And that's an untoward effect. It has the exact opposite effect of what we would expect to have happen. So administering or assisting with medication is a serious responsibility. We can really hurt somebody. We can kill somebody. So this is something that we don't take lightly. Okay, you need to know the medication. You need to use good judgment. And very importantly, you need to know the 5 R's, the 5 rights of giving a medication. So the 5 rights, is this the right patient? Okay, that seems kind of obvious because you have a patient in front of you, but is it the right patient for that medication? Okay, is the medication that we have the correct medication for the situation that the patient is in? Okay, I'll give you an example. A lot of people are on nitroglycerin for cardiac problems, and a lot of people think when somebody's passed out and down that, hey, I'll give them one of my nitroglycerins because it helps for things like that. No, it doesn't. It could actually make them worse. Nitroglycerin, one of the side effects is it lowers blood pressure. And this person's already passed out, might be because their blood pressure is already low. So I've gone on several calls where somebody said, I gave them one of my nitros. And it's like, no, don't do that, okay? Is it the right time to administer medication? Some medications, you can give them more than 1 dose, but you have to have an intervening period of time before you can do that. A good example of that is Narcan. A lot of people, especially lay people, will administer Narcan intranasally to a heroin overdose, somebody that's not breathing or barely breathing. And they expect them to wake up right away. Well, it takes, 2 to 3 minutes for that to start taking effect. And so what happens is lots of times we'll get on a scene and they said, I've already given him 4 doses of Narcan, he's not waking up. Yeah, but if you're giving them 20 seconds apart, it's not getting time to work. Okay, so it has to be the right time to administer a medication. Is it the right dose? Are we giving them the correct amount of that medication? And are we giving it by the right route of administration? There are different routes of administration. So for EMTs, oral, we can give somebody medication and they can chew it or swallow it. In the case of nitroglycerin, for example, or in glucose, some glucose, we can give it under the tongue, and that's called sublingual. sublingual, so it's dissolved under the tongue. We have medications that we can administer through a metered dose inhaler or a nebulizer. We'll talk about those. And they're breathed into the lungs, okay? And as we mentioned before, Narcan is intranasal, where we squirt some fluid in there. And as an EMT, there's one situation where you can actually inject a medication into a muscle. And we'll talk about that a little bit. There are other routes of administration, you know, for paramedics and nurses and doctors and everybody, but not at our level. Intravenous means it's injected into a vein. Subcutaneous, it's injected underneath the skin. Interosseous, we can actually put medications into bone marrow as a medic. We have a drill. It drills a hole into the bone. It's usually the tibia or sometimes up in the shoulder bone. And then we can run fluid or medications into the bone marrow, and then it gets rapidly absorbed into the bloodstream because, again, bones have blood vessels, right? Endotracheal, if they have a breathing tube that's been passed into their lungs, there are certain medications that can be administered right down that tube to get into the lungs, and then it gets rapidly absorbed. Whenever you give a medication, you have to reassess your patient afterwards. And then you want to make sure that you're documenting everything, the time that you gave it, the dose that you gave it, all of those sorts of things, the R's, if you will. So different medications that as EMTs we can administer. First one, aspirin. Okay, so we can carry aspirin on our rigs. And aspirin is seems innocuous, but it's a medication that we'll give for somebody that we think may be having a cardiac problem. Okay, so it's in the cardiac protocol. Okay, and we've given you the link to the state protocols. So you want to make sure you're checking those. And we can give it if they've not already taken aspirin and they have no aspirin allergy or recent gastrointestinal bleeding, because, you know, aspirin can make their bleeding a little worse. And we're going to administer 324 milligrams of non-enteric chewable aspirin. Non-enteric means it's not coated. It's not coated with something. That's regular baby aspirin. So 324 milligrams, how many aspirin is that? Well, let's go back up and look at the bottle. And right here it says 81 milligrams each. 81 milligrams each. So that means to give 324, you're going to have to give them 4 baby aspirin. Okay, so that's the right dose for aspirin for a cardiac patient. Another medication is oral glucose. This is for diabetics who are hypoglycemic, their blood sugar is too low. And we haven't talked about diabetes yet, but we will be in a couple weeks. And we'll explain more about that then. But the normal blood sugar is somewhere in the 90s, give or take. When it gets down around 60 and below 60, people start having some weird effects to that sugar being that low. And again, when we talk about diabetes, we'll talk about that. But these people will get altered mental status. They may get goofy, they may get combative, they may get sleepy. But the big thing is if we're going to take this gel, it's a gel, that's the form of the drug in this case, and put it on a tongue blade and put it inside their cheek, maybe sublingually under their tongue, or have them just squirt in their mouth and have them swallow it. They have to be alert enough to protect their own airway. If they're sleepy and you got to wake them up, and don't be putting goop in their mouth because they'll aspirate it. Okay, at that point they're going to need to have sugar put in intravenously. Okay, so we give them 1 tube slowly. That would be the dose. 1 tube, 25 grams. Or if they're alert enough but their sugar is low, because you'll be checking blood sugars. Now that's not something we do in the class here, but once you become an EMT, then you take a very short class to learn how to do blood sugar determinations. But you can give them other carbohydrates, you know, soft drinks that aren't diet, okay, candy bar, a sandwich, maybe milk with a little sugar in it, orange juice with some extra sugar in it, things like that, as long as they can protect their airway. For us, oxygen is a medication. We dose it, right? How many liters per minute? Activated charcoal, we used to be able to give this for poisonings, but they've taken it out of our protocol now. So if you guys have, back in your squads, if you have activated charcoal on your squad, you can get rid of it. It's really nasty stuff. It's a slurry, and it's charcoal slurry. So it's black, and then it's half the time, because it's a poisoning, we have them drink it and then they throw it up and it's a mess. So terrible. But it's been taken out of our protocol. So if it's on your rig, get rid of it. Another one is a bronchodilator inhaler. So this is a meter dose inhaler. And there are also meter dose inhalers for other things than bronchodilators, like steroids. And that's not what we use, okay? These are pre-prescribed for patients that have asthma and chronic obstructive pulmonary disease, things like emphysema and chronic bronchitis. What we want from a bronchodilator is to enlarge those breathing tubes, because they've been constricted. We'll talk more about it in just a few minutes. Some of the side effects: it's going to increase heart rate, and patients are going to get shaky and jittery. But the big thing is we don't give the steroid ones. So things like Max Air, Advair, things like that, those are not rescue inhalers. What we're talking about here, a bronchodilator is a rescue inhaler. When they're having a problem breathing, that's the one they use to try to alleviate that difficulty breathing. The steroid ones are maintenance. They're the ones you take once or twice a day, every day type of thing. That's not what we're talking about. We're talking about a bronchodilator that opens up the bronchial tubes. Contraindications: it's not the patient's, okay? That we don't give them somebody else's meter dose inhaler. If they're tachycardic, once they get up in the 140 range, and we give them a bronchodilator, because that increases heart rate, their heart rate start beating too fast and doesn't have enough time to fill with blood to pump it back out. So the tachycardia, once you get up close to 140, we don't use the bronchodilators. The patient's not alert, you just have to follow your directions. And they probably already know how to use it, but if they're in distress, you need to help them and coach them through the process. And if they've already taken it and they've reached the maximum dose that's on the bottle. So there's a very short video here that I want you to click on and watch. And it's just a boy, shaking and using his meter dose inhaler, so you can see how that works. Okay. Another one is nebulized albuterol. Now, albuterol is a bronchodilator, and we can give it in a nebulized form, which means we put it in what's called a rotohaler. So we're going to put fluid in this thing, attach it to oxygen. It's attached to a mask, and this thing spins around and basically vaporizes and nebulizes the albuterol, and then they inhale it through the mask. Okay. So this is the protocol for using nebulized albuterol is for patients between 1 and 65, and they're having an exacerbation of their previously diagnosed asthma or COPD, chronic obstructive pulmonary disease. Exacerbation means a worsening of a pre-existing condition or a chronic condition. Exacerbation. So in anybody that's having difficulty breathing, you're going to be calling for ALS, okay? If you have a patient with a history of basically heart problems, you probably need to contact medical control and see if it's okay to give it, because again, albuterol being a bronchodilator is going to increase heart rate. And if that patient's at risk for having cardiac issues, we may not want to be doing that. On the other hand, we may, depending on how severe their difficulty breathing is. Again, this is not something that you're going to come out of this class to be able to do. There's that extra little class that you need to take to do nebulized albuterol as well. But you have to be an EMT first in order to do that. And then again, there's another link here to a YouTube video that talks about using the rotohaler and how you apply it to the patient and the liter flow you need to have it at, etc. So you need to watch that. Okay, nitroglycerin. So again, taken by patients with history of chest pain or cardiac origin. Okay, what we hope it does is we hope it dilates coronary blood vessels, the arteries that feed the heart muscle. The other thing it does is it'll dilate other blood vessels in your body. Okay, so when it does that, you have a good chance of lowering your patient's blood pressure to the point where they maybe pass out. So in the case of nitroglycerin in New York State, And this is something that's a little different than what's in your book. In the book says the contraindication is if their blood pressure is 100 or less, systolic pressure. In New York State, it's 120. Okay, so their blood pressure, their systolic top number blood pressure needs to be above 120 before you can assist somebody taking their nitroglycerin. Nitroglycerin is not something we carry in an ambulance for a basic EMT. It has to be the patient's, okay? It has to be theirs. They have to have a desire to take it. You can help them, you can get it out of the bottle. I would make sure you have gloves on because it's going to dilate blood vessels, and some of those blood vessels are in the head, and you can get if you touch that nitroglycerin, you're going to get a severe headache because it'll get absorbed through your skin, okay? So again, contraindication is the pressure's below 120 systolic, and the side effect is it's going to drop blood pressure as well as give you a headache. Okay. Epinephrine. There's a couple different ways that we can give epinephrine. A lot of patients have an auto injector. This is a spring-loaded device that we take a cap off and we hold it up against their lateral thigh and push it in, and it activates that spring, and it slowly injects, well, the spring will take the needle and inject it into that thigh muscle, and then it will push that epinephrine medication into their muscle. So we do this for severe allergic reactions, and those severe allergic reactions are called anaphylaxis. We don't do it for normal allergic reactions. It's overkill. We only do it when it gets to the point where it's potentially life-threatening, which we call anaphylaxis. We can carry these on the ambulance, okay? So it could be a patient's prescribed EpiPen, Epi auto-injector, or it could be one that you carry on your ambulance. It's an intramuscular injection, okay? So we're gonna inject it into a muscle, and we wanna inject it into a pretty decent-sized muscle in most cases. And you are going to, because EpiPens are very, very expensive, the state doctor group, it's called the CMAC, came out with a new protocol that allows us to do syringe epinephrine. So that's just like giving a shot to somebody if you were in the hospital or the doctor's office. So we need to teach you how to do that. In the case of giving epinephrine with a syringe, we will give it in the deltoid, the upper arm, okay? And there's another video here that the state wants you to watch. This is at their suggestions, about, I don't know, I'm guessing 12 minutes or so. But it's a nurse showing folks how they're going to give an intramuscular injection into the deltoid muscle, okay? So you need to watch that video as well before Thursday. We doubled up. There we go. Narcan, we mentioned this before, it's intranasal. There's a YouTube video, okay? And there's I have to find the PowerPoint put out by the medical directors about it. But again, it comes in a couple different forms. There's some it's a vial that you pop the tops and you screw it together. And then they also have some that are just about this big around and they're white, and it's got a plunger on it. You're going to be able to see both types out there out in the field. So we give Narcan for suspected heroin overdose. How do we know if it's a heroin overdose? Somebody will tell us because somebody called. Hopefully they're still there. They're not responding. They have pinpoint pupils, but worst of all, they're barely breathing, if they're breathing at all. Okay. So with this one, you're going to start out by bagging a patient. And when you get the Narcan ready, whichever form style you're using, then you stop bagging and squirt half of it in one nostril, squirt half of it in the other nostril, and then resume bagging. Okay, and it takes 2 to 3 minutes for it to fully work, and then they'll wake up. And sometimes they wake up and they're fighting, so be prepared for that. Okay, so again, watch the video. Again, unresponsive, suspected heroin or fentanyl, it's some sort of opioid type of overdose. They're going to get cyanotic. They're going to have, blue lips and fingertips, quite often we'll say, things like that. And it tells you that, they're in deep doo-doo. So Narcan, there's no contraindications to Narcan. You can give it to somebody that's awake like us now, won't do a darn thing, okay? No contraindications. So reassessment documentation are important elements. So if you're gonna give a medication, you're gonna document why you gave it, indications that you gave it, what time you gave it, and any response from that medication that you saw in your patient, if any. All right, now we're gonna move on and talk about some respiratory emergencies real quick. Just a quick review of the anatomy and physiology. We have trachea coming down. It's gonna go, splits at the carina here, and we have a right main stem bronchus and a left main stem bronchus. You'll notice that we have 2 lobes to the left lung, and on the right side, we have 3. Interesting, right? That's because the heart sits in here. It takes up space, so there's only 2 on the left side. Excuse me. The central portion of the chest is a million-dollar word we call the mediastinum. That's the bronchi, the aorta, the vena cava coming back up. All that stuff in the center and the heart is all called the mediastinum. Again, like any organ, there's a tissue surrounding it. In the case of the lungs, we have 2. Remember that, we have 2 pleura. Visceral pleura is the one that adheres right to the lung surface. And then the parietal, remember parietal was a word that means side, like the parietal bone in the skull. This one adheres to the inside of the thoracic or chest wall. And they're in contact with each other. There's just a little bit of slippery fluid in there, so that when the rib cage expands, you know, the ribs go up and out to take a breath in, that visceral pleura goes right with it, and that's why everything works. And then when, I'm sure that Rob was talking about chest injuries, we have a pneumothorax. That's when air gets in between those 2 pleura and they separate, and then the lung collapses down, whether it's gunshot wound, stab wound, or whatever. It could even be spontaneous. Okay. So inspiration, we've talked about this. It's an active process. Muscles contract, increase the inside chest cavity. Intercostal muscles contract, the diaphragm moves down, ribs move upward and outward, and that forces the air to be pulled into the lungs. Expiration or exhalation is a passive process. Just everything relaxes, chest size, or the chest cavity size decreases, and there's more pressure in the chest, air goes out. So real quick, again, adequate respirations. We have a normal respiratory rate. There's a good depth or excursion of the chest, good skin color, nobody's blue, anything like that. Inadequate respirations. There's increased respiratory effort. Quite often people are laboring to breathe, they're working to breathe, working to breathe. There may be an abnormal rate. They may be using the accessory muscles, you know, like their nose is flaring, the neck is hollowing out. Tripoding, that's a position that they're in. They're trying to increase the chest size. They'll be sitting up and maybe a little forward. When they speak, they're not speaking in full sentences. It might be things like, I've been having trouble breathing for the last 2 days. Things like that. They can't speak in one full sentence in one try. We may hear abnormal sounds. We could hear, you know, gurgling, snoring, wheezes, a stridor, a high-pitched squeaky sound, crowing, barking, a lot of different sounds. They could be pale or blue, pallor or cyanosis. And when you listen to their lung sounds with a stethoscope, they're diminished. And we always compare one side to one side, one side to one side. And we listen high and wet, we call it, up near the armpits first, because that's the place where you're listening on one side versus the other side. You have less the likelihood of hearing lung sounds from the other side of the lung, the other lung. So we start out here, listening to lung sounds. And then we, at least 4 places in the front, at least 4 places in the back. And you compare the 2 sides. So somebody that's having a respiratory problem, to start out with, when they're just having some difficulty breathing, we call it dyspnea. There's that pnea again. Dys means difficult or painful. So dyspnea, somebody's having a little trouble breathing, we call it dyspnea. As that progresses and gets worse, when they're really starting to labor to breathe and all of that, we call it respiratory distress. Respiratory distress. They manage that for a while, and then they start going downhill. And when they start going downhill, we call that failure. At this point, they're going to have some altered mental status. They may get sleepy. Their excursions are not as good as they were. Their vital signs are starting to get crappy. Excuse me. And eventually, they'll get down to respiratory, I should say respiratory arrest on that last line. I should say not distress, but arrest. So they have dyspnea, so they give you dyspneic, and then they get respiratory distress, then it progresses to respiratory failure, and eventually ends in respiratory arrest, where they stop breathing. Normal respiratory rates, we're 12 to 20 as adults. The younger we are, the faster we breathe, okay? An infant could be breathing almost every second, just almost, okay, in some cases. And usually the rhythm is regular. The breath comes when we expect it to. And there's no funky sounds, okay? The normal breath sounds, and they're equal on both sides. So some of the conditions that we can run into, asthma. Asthma is an episodic disease. It comes and goes, and normally in between, the patient's fine. An acute problem is one that suddenly occurs. A chronic problem is one that they have all the time, and then may exacerbate or get worse periodically, but they always have that problem. With asthma, in between, they're usually fine. Okay, so we call it episodic disease. And reactive airway, which means our airways are reacting to something. And there's a couple different reasons to have asthma. But the way they react is those airways get very narrow, and they can have increased mucus production. Okay, so they can be triggered by a variety of environmental issues. They breathe in smoke or something, you know, pollens, whatever it happens to be. And sometimes anxiety or emotional reasons will cause trigger an asthma attack. Big thing with asthma is recognizing it, and that's with wheezes, whistling sounds. And they can be on inspiration or expiration, but you'll hear a whistling sound. And we're going to have something, I'm not sure if I'll have it ready for you for Thursday, but we're going to have you listen with a stethoscope. We have these things called sounders, and we can dial up different lung sounds that you can listen with a stethoscope. So you can hear what wheezes sound like. There's other sounds like rails, which are crackles. There's rhonchi, which is kind of like a crackle, but it's more in the larger airways. So it's more of a little bit more of a gurgle type sound. But we'll give you a chance to listen so you can hear what those are. So you'll be able to recognize them when you're taking care of a patient. Then we have chronic obstructive pulmonary disease, COPD, and that's a catch-all term for a bunch of different types of problems. Chronic bronchitis, emphysema, asbestosis, black lung, coal miner's lung. There's a host of these things. What's happening here is there's been damage to the linings of the respiratory tree, okay? And we have cilia, which are like hair-like things coming off the cells that kind of hopefully waft bad stuff away. They get paralyzed in many cases and don't work anymore. So we also with COPD have a lot of excess mucus production, and it causes air to essentially be trapped in those alveoli. And in the case of emphysema, the sac, the alveolus, doesn't work like it's supposed to. Normally it moves, okay, to allow air to come in and out. Remember, surrounded by capillaries, that's where all the gas exchange takes place. So, especially with emphysema, that process that just doesn't work anymore. So air gets trapped in there. And with mucus, it also blocks the airway to help keep air trapped in there. And when that happens, then gas exchange is not taking place. So if we look at an alveolus here, a lot of mucus, a lot of junk, and the air gets trapped in here. And over years and years and years, okay, this is a process that develops. And so when you see a patient that has COPD, there's some characteristic things. They're always Look at this guy. Okay, he's tripoding. See how he's sitting up and leaning forward? Also, quite often they'll have a barrel chest. So with most of us, the anterior to posterior length of the chest is shorter than from left to right. So our chest is like a rectangle. And people with chronic obstructive pulmonary disease, because they've had this trapped air for years and it's not getting any better, the chest gets like a barrel. It gets rounder. It's kind of like, it's kind of like a bubble, okay? And over time, those trapped air is making that chest get a little deformed, if you will. So we call that barrel chested. You can tell this guy doesn't look good. He's struggling to breathe. He's flaring his nostrils. He has pursed lips too. They're forcing air out. We'll try to maintain some back pressure to try to keep those airways open during exhalation instead of closing down totally. They could be wheezing, could be snoring, could have stridor, high-pitched crowing type sound. Okay, could be almost anything. But they look like they're in trouble. And this is part of your general impression. You walk in and you see a guy like this, you know you got a problem, okay? Another situation we could run into is congestive heart failure. Basically what's happening here is the heart is a double pump. And we're going to talk about cardiac stuff on Wednesday. It's a double pump. So the right side is pumping blood to the lungs. And the left side is pumping blood to the rest of the body. So it's like two pumps, right? So if one side is failing because of heart disease, it can't pump out as effectively. Therefore, blood tends to back up. And when it backs up, fluid, plasma, will leak out of the blood vessels into the tissues surrounding the capillaries. So if it's the right side that's failing, it's getting its blood from where? The body, right? Blood's coming back to the right side of the heart from the body. So it will back up in the body. Now, where it backs up in the body is those areas of the body that are closest to gravity. So if there's somebody that's always sitting up because they have trouble breathing, it's going to cause fluid to leak into the tissues around their feet and their ankles. We call that pedal edema. If it's the left side that's failing, the larger side of the heart, because it's trying to pump to the whole body, right? The blood's coming into the left side from the lungs. So it backs up into the lungs, fluid leaks, and gets into the lung tissues. When it gets into the lung tissues, we call that pulmonary edema. Edema means fluid in the tissues. Pulmonary edema, so fluid in the tissues in the lungs. And again, on the right side, it could be pedal edema. If there's somebody that's bedridden, their closest point to gravity would be their bottom, right? And so they have sacral edema. They'd have a lot of swelling down by their sacral bones and in their butt. So congestive heart failure. So when it leaks into the lungs, pulmonary edema, they're going to have difficulty in breathing, okay? Somebody could have a pulmonary embolism. Remember the word embolism? Remember we said that's something that's going down an artery until it gets stuck. We had air embolisms when we had a possible big neck laceration. In this case, it's going to be a blood clot that broke off from somewhere. Maybe they had, blood clots in their legs, and they got sucked into from a vein, and it goes back up into the right side of the heart, and then it gets pumped out into the lungs until it gets to a point where it sticks. It gets down so, arterioles are smaller until boom, it just stops and plugs that up. So it's going to block blood flow to that portion of the lung that would be getting perfused past that point. And when that happens, gas exchange cannot take place. And they're going to have difficulty in breathing. And they're going to have an increased respiratory rate, and they're going to have a decent amount of chest pain, okay? And their respiratory rate quite often will go up very fast. And the problem with that is it can mimic something called hyperventilation syndrome. Now, hyperventilation syndrome is a case where you have somebody who's having some sort of emotional distress, and they start breathing really fast. And when they breathe really fast, they're exhaling too much carbon dioxide, and that screws up their blood chemistry. Remember we talked about pH a while back? So it's going to make their pH level go down, more acidic, going up, so less acidic. It's going to be more on the basic side. And that causes increased chest pain, and it also causes certain muscle contractions in the hands and the feet. You'll get cramps. That's typical hyperventilation syndrome. Back in the old days, we used to say, get a paper bag, have them breathe in and out into the paper bag. That way they're rebreathing carbon dioxide that they've exhaled to try to get that pH level back to where it should be, okay? We don't do that anymore because there's other reasons for people to be breathing fast other than, my boyfriend just left me, okay? It could be a pulmonary embolism. And now we're having them breathe into a paper bag instead of giving them oxygen like we should, okay? Another thing is, and again, the typical person that's hyperventilation syndrome is a young female, somewhere, 15 to 25, okay? Something like that. The other problem is girls that are a little bit older than that, older than 15, are at risk for pulmonary embolism. Why? Because they take birth control pills. And birth control pills sometimes can cause pulmonary embolism. So now we've got this 21-year-old that's breathing fast, and we think it's hyperventilation syndrome, and put a paper bag over her face, and when she's actually having a pulmonary embolism, she needs oxygen. Okay, so no paper bags over the face of people anymore. Another reason for difficulty breathing is pneumonia, which is an infection. Could be bacteria, viral, could be any type of thing. So we get germs in us and they grow and cause inflammation in our lung tissues. So difficulty breathing, a fever, maybe have diminished lung sounds, maybe even hear some funky sounds in there from the pus and stuff that's basically in their lungs from this infection. You could have a spontaneous pneumothorax, doesn't have to be caused by trauma. Some people will get little lesions on their lung, they're called blebs, and then they rupture and they cause air to leak into the space between those two pleura. Very tall, thin people, it's called Marfan syndrome, just as an aside. They think that Abraham Lincoln had it because he was tall, had a tall, thin chest. But those are the people that tend to have a spontaneous pneumothorax. All of a sudden they get, boom, sudden severe pain, maybe they coughed or something. And then when you listen to the lung sounds, you may or may not hear diminished lung sounds on the side where their pain is. Sometimes when they have a pneumothorax, the lung doesn't collapse all the way down, it just collapses down like 10%, and it kind of seals itself off. Those you're probably not going to pick up by listening to lung sounds. It has to be found on an x-ray. So again, evaluate effort to breathe. If they have poor air movement, we got a problem. They may have increased heart and respiratory rate. They may start getting cyanotic, the blue lips, fingertips thing, and they're going to start having altered mental status. They could have wheezes, they could be coughing, they could have that high-pitched stridor bronchi, which are the more gurgled sounds in the center part of the chest and the bigger bronchial tubes. Snoring from a tongue partially blocking the airway. Crowing, like kids that get croup, things like that will crow. And other gurgling from fluids in there, and crackles or rales, R-A-L-E-S, rales, from fluid down in the alveoli, and it's the air popping out through a fluid layer. And then they could have decreased breath sounds on one side or the other. And look at how they're sitting. Remember that gentleman, okay? So, what's going on here? Okay, so treatment, obviously take care of the ABCs, obviously give them oxygen. If their pulse oximeter reading is less than 94, we definitely give them oxygen. And I don't know if you guys have had a chance to practice with it, but that's the thing we put on a finger. It measures the percentage, of oxygen saturation in the hemoglobin in the blood. Sometimes we need to ventilate these people. Anybody with a respiratory rate of less than 10 that's having an issue, we need to bag them. We need to take over breathing for them. Less than 10, we consider them not breathing. That's not enough to sustain life unless they're like a long distance runner and, you know, they're great shape and they're always breathing at 9 times a minute or something. Less than 10, you got to ventilate. Also, you probably may have to ventilate once they get above 29. Again, depending upon what kind of distress they're in. If you have a COPD patient that's getting sleepy and really fast respiratory rate, you're probably going to have to lay them down and start bagging them. Okay. You can bag somebody that's even awake. It doesn't hurt. It's all latex, plastic, right? Put them in a position of comfort. Usually when they're having difficulty breathing, it's sitting up unless their blood pressure is low. And then we're going to have to set them back, lay them down some, okay? Again, anybody with difficulty breathing is a reason to call for advanced life support. Now you can assist with their metered dose inhaler, or you can do the nebulized albuterol once you get credentialed, okay? All right, allergic reactions. So we have an immune system and hopefully it works correctly. And so sometimes we'll get a foreign substance inside our body, and it would be a foreign protein of some kind. And the body doesn't like it. And the immune system kicks on. So that foreign protein we call an allergen. And we can have an allergic reaction to that allergen. Excuse me. And that allergic reaction is the body's normal response to go fight that allergen, is what it is. And things get released, chemicals, histamines, things like that. And it gives us other symptoms too. So the first time somebody's exposed to an allergen, they don't have a reaction to it because the body doesn't have any antibodies. Once we've been exposed, so the first time somebody gets stung by a bee, they're not going to have a reaction to it. The body then develops these antibodies to fight off this allergen the next time it comes. So the next time they get stung by the same type of bee, then, well, they could have an allergic reaction to that, okay? So subsequent exposure to that specific allergen, and there's antibodies are for a specific allergen. If you get another allergen comes in, your body's going to make antibodies for that allergen, okay? So once you have been exposed, and if you get exposed again, in some cases, you can have allergic reaction to that. And that could be swelling, you could have some hives, you know, sneezing, watery eyes, you know, things like that. Those are normal reactions to allergens, okay? Not a big deal, not a big deal. Sometimes though, we have a full-blown allergic reaction. And we're going to have hives and a lot of swelling and things like that. Then it can go one step further, and we call that anaphylaxis, and that's a life-threatening allergic reaction. Okay, there's a difference between a full-blown allergic reaction and true anaphylaxis. Okay, so common things: allergens, bites, stings. People could be allergic to certain foods. You know, nuts are very, very common. Plants, animals, dander from pets, things like that. Be allergic to medications. Latex, we don't use latex gloves anymore in medicine, at least we shouldn't be, because a lot of people have a latex allergy. So regular allergic reaction signs and symptoms, it could be local, so you get stung by a bee, it's going to swell up right there. If it's something that you inhaled, you could be coughing, you could be sneezing. You could also have hives. The medical term for hives is urticaria. I have a picture of that for you in a minute here. You could have some tingling in the extremities. The vital signs are going to be relatively normal, okay? You're just having this reaction happen. It's not messing up with your body's system at this point. They could have some dyspnea. They could have some tightness in the chest, okay? And once that happens, then we start talking about it being anaphylaxis. The anaphylaxis, you have to have difficulty breathing or signs and symptoms of shock, okay? So they're going to have difficulty breathing, get tightness in their chest. They could be wheezing. They could have stridor. It could be tachypnic, which is the fast breathing rate. They could have hives all over their body, not just in a certain area. Swelling of the face. And again, what's happening here is our blood vessels because of this histamine and immune response going on, our capillaries are getting leaky, and they're leaking fluid out. And that's what's causing the dyspnea, fluids getting into the lungs, tightness in the chest because there's fluid in there and we're trying to take a bigger breath. The fluid in there is going to cause the wheezing. The fluid is going to cause a constriction in our larynx, which is going to cause us to have that stridor, that high-pitched, crowy, squeaky sound type breathing. Swelling of the face, again, fluids leaking into the tissues. They could be pale or they could be flushed, okay? Either could happen. And they're going to be tachycardic and they're going to get hypotensive. This is where our signs and symptoms of shock come in, okay? They're going to get sick to their stomach and they're going to have, they could have uncontrolled diarrhea. I've seen that in a couple patients. When you see a true anaphylaxis patient, it's scary. It's very scary. They're dying in front of you, basically. So somebody's got hives, a little swollen. It's not that huge a deal, but when they start getting difficulty breathing or other signs of hypotension, signs and symptoms of shock, that's anaphylaxis and we gotta move fast, okay? So that's what hives look like, okay? Raised areas, fluids getting into the tissues there. This is a guy that's flushed skin, okay? Kind of common. So allergic reactions can have any of those individual signs and symptoms, but once they have respiratory distress or signs and symptoms of shock, then we call it anaphylaxis, and that's when they get epinephrine. If they have an EpiPen, then we can assist them using the EpiPen. With EpiPens, actually, you can shoot them right through pants, okay? Again, we're talking, we got a big problem here. And again, true anaphylaxis starts within minutes. If it's somebody that had nuts an hour ago and then they're saying they're having anaphylaxis, no. They might be having an allergic reaction, but it's not anaphylaxis. Anaphylaxis comes on quick and is scary, very, very scary. So obviously ABC stuff, oxygen, figure out what it was that they got exposed to. Maybe they got a chemical on them that they're allergic to and it's still on their clothes, things like that. You may have to decon. Obviously, if they're going down the tubes, you're going to call for ALS and they get epinephrine. So you're either going to draw up epinephrine from a vial, we're going to practice that, or you're going to use the EpiPen. So it's common for people to have auto-injectors if they have a history of allergies, of, you know, reacting to a bee sting, that sort of thing. Epinephrine is a common hormone produced in the body. But what we're giving it for is to constrict blood vessels to stop fluid from leaking and going into the tissues and causing swelling and things like that. That's going to give us difficulty breathing. It also dilates the bronchioles, so it makes it easier for us to breathe. So as an EMT, you're authorized to carry epinephrine on your ambulance, and it can either be in an auto-injector form, which is, as I said before, very expensive, or you can have a vial of epinephrine and then a syringe and a needle. The adult dose for epinephrine is 0.3 milligrams, 0.3 milligrams, and we'll show you on this, with a syringe how to figure that out. And if you have a pediatric case, somebody that hasn't reached their 15th birthday yet, the dose would be 0.15 milligrams. And on Thursday, we will practice that. All right, so make sure you go through and look at all the YouTube videos. There's one in there for IM injections that you have to watch. There's one for meter dose inhalers, and there's one for nebulized albuterol. All righty, and that's it for this particular lecture. And we'll be doing live cardiac on Wednesday and then practice on Thursday. So everybody have a good rest of your day.